today's educational activity titled Diagnosis and Individualized Management of von Willebrand Disease, Expert Perspectives on Synthesizing and Contextualizing the Evidence. Today's program is supported by an educational grant from Takeda Pharmaceuticals. And it's also brought to you by CME Outfitters, an award-winning accredited provider of continuing education for clinicians worldwide. We want everyone to join us also on our live Twitter conversation at CME Outfitters. We're using an enhanced platform today that allows you to save slides, take notes on slides, answer polling questions, and then send us your own questions. Please look at the tabs below the slide viewer and at the top of your screen and give us your feedback on this platform as well as the program. So let's get started, and I want to start it by introducing myself. My name is Dr. Robert Sidonio Jr. I'm a pediatric hematologist. I work as an associate professor at Children's Healthcare of Atlanta and at Emory University. I'll be the moderator of the program, and I'm joined by my two colleagues who will introduce themselves. Let's start with Dr. Escobar.
Yeah, good evening. Thank you, Robert. My name is Miguel Escobar. I'm an adult hematologist and professor of medicine and pediatrics at the University of Texas in Houston. I'm the director of the Hemophilia and Thrombophilia Center as well.
Thanks, Miguel. Now, Dr. Roberts.
Yes, hi, good evening. I'm Jonathan Roberts. I'm the Associate Medical Director at the Bleeding and Clotting Disorders Institute and also an Assistant Professor of Pediatrics at the University of Illinois College of Medicine in Peoria. And our clinic is also a lifespan clinic, so we take care of pediatric and adult patients.
That's great. So we have two great speakers joining me tonight. Let's go ahead and get started and dive in with our first learning objective, accurately diagnosing von Willebrands based on clinical assessments and laboratories, specific laboratory assays. So we know that von Willebrand's is the most common bleeding disorder in humans. It was discovered in the early 1900s by Erich von Willebrand. And most notable, the index case was a little girl named Hjortis who presented with bleeding symptoms that were more typically seen in males with hemophilia. Ultimately, she passed away after her fourth period. We know that the characteristic bleeding signs and symptoms are typically associated with mucocutaneous bleeding, but also associated with things like musculoskeletal bleeding, joint bleeding, but a lot of easy bruising, frequent nosebleeds, heavy menstrual bleeding in women, and a lot of oral bleeding. We know that it's equal amongst both genders and ethnic groups. Typically is seen a little bit more commonly in Caucasian populations, as this origin of this disorder is in Northern Europe. And oftentimes it is not diagnosed unless there is a hemostatic challenge, unless there is a family history noted. And of course, the severity goes from severe to mild, with the majority of the patients being in the mild range. So I'll go ahead and get it started here. Dr. Escobar, you see the slide here. Do your patients typically present in your clinic? You said you're an adult provider. They typically present with these symptoms?
Yeah, I mean, as you already alluded, the presentation could be quite variable. But you know, in our adult population, we have patients that come in just with simple, easy bruising. Mm-hmm. The women, certainly, it's going to be quite common, the menorrhagias, I think. But many of them have had it for years, and they have not been addressed correctly. Many of our patients actually also come for surgeries, you know, with a history of von Willebrand sometime in their life or a family history. So the surgeons might get a little bit uncomfortable and they'll send it to us, you know, to do a workup. Or sometimes actually we're seeing a lot of from the OB/GYN service, you know, they're pregnant and they have this history of von Willebrand and they get sent to our clinics for an evaluation,
Sure.
You know, kind of planning for that delivery.
So Jonathan, do you get the same history where maybe somebody has a remote history or they're about to have a procedure and they may have remembered 10 years ago that they were diagnosed with von Willebrand's maybe as a child?
Sure. Yeah. For adults that present to us, we definitely have encountered that where they may have remembered something about von Willebrand disease, and then the next time they come to see us is after they've had some major bleeding complication in surgery, or the surgeon calls because there's an inpatient that's having uncontrolled bleeding and they're unable to get it to stop. So yes, we do have those similar type of presentations. I would say also in pediatric patients, very commonly we'll get referrals for easy bruising, girls attaining menarche, and then also patients that may be bleeding post-operatively after a tonsillectomy, adenoidectomy, or maybe even dental worth, having multiple dental extractions or wisdom tooth extractions. These can be ways that patients will present. In a perfect world, if we've done our job right and there's a family history and the patients are educated about von Willebrand disease, we also will get siblings or family members that we can then diagnose them preoperatively and put a management strategy in place for mitigating any bleeding risk they may have.
Yeah, and we'll talk a little bit more about the team together that's key to trying to make a diagnosis not urgently at the time of surgery. So moving forward, as everyone knows, von Willebrand factor plays two critical roles. First of all, it's a multimeric protein, and it's consisted of dimer, what we call building blocks, and it forms something called multimers. They're stored in endothelial cells and megakaryocytes. And then they're secreted into plasma, where they play a critical role in primary hemostasis. As you can see here, one of the roles is tethering the platelet to the exposed or damaged collagen. And the other critical role, it serves as a carrier protein for factor VIII, preventing premature degradation. So Jonathan, why don't you walk through the different types? We just talked about the pathophysiology, and there are multiple types and multiple subtypes as you listed here. Why don't you take us through this and tell us a little bit about some of these?
Sure. So from a big picture standpoint, there's three main types of von Willebrand disease, and you can see there's subtypes listed there at the bottom of the slide. By far the most common, around 80% of the time, is type 1 von Willebrand disease, where it's simply a partial quantitative deficiency. So not having quite enough von Willebrand factor present to stick platelets to the site of injury, to bind collagen, to chaperone factor VIII to the bleeding site. So that's by far what you'll encounter in patients in your practice that have von Willebrand disease. Next would be type 2, which is somewhere around 20 or so % of patients. And this is a qualitative defect. So there's a functional deficiency in von Willebrand factor. So sometimes the level's reduced, sometimes it's normal. But as you can see, there's different subtypes there where there could be abnormal binding to platelets, either a lack of platelet binding, such as 2A or 2M, or an enhanced gain of function binding that can also lead to thrombocytopenia in type 2B, as well as deficient factor VIII binding in 2N that sometimes can be mistaken for mild hemophilia. Those type 2 variants will require more sophisticated laboratory testing, really to hash out what the specific qualitative defect is in the von Willebrand factor molecule. And then type 3 is essentially complete deficiency of von Willebrand factor. And these patients present often like a severe hemophilia because, as Robert mentioned, von Willebrand factor is critical for chaperoning factor VIII in circulation. And so if you don't have factor VIII or von Willebrand factor in circulation, you also don't have factor VIII unless the VWF is replaced. So that's kind of a big picture view of the diagnostic classification, and we'll talk a little further in the coming slides.
And sure, of course, we don't expect primary care providers to help discern the different types. That's our job. We just want you to make sure you get them to us to make sure that we can help make that appropriate diagnosis. So critical to this is, just recently, multiple organizations, ASH, ISTH, NHF, and WFH, decided that they wanted to get back together and have a unified set of guidelines. And the last set of guidelines had been decades before. It was a pretty large effort, took multiple years to put together, required a lot of coordination, a lot of meetings. And they ended up with two sets of groups. They set priority questions, so we couldn't address everything that we would like to address, but we decided to prioritize some questions to address that we felt were pertinent. And 2 documents came out of this. One was focused on the diagnosis. That's listed there, first authored by Paula James. And then the other, there was a second one was authored by Nathan Connell, and that focused on the management of von Willebrand's. And we'll go through some of this. We're not going to go through all of the details, but there's a larger algorithm. If you go to the document, it's free online. And it starts with a patient suspected of von Willebrand's. And then from that, then decisions are made. And then, you know, it branches out into what happens. And one of the first things that you should do, and I think anything in medicine starts out getting a good history. From there, the decision on additional testing and how much testing goes on depends on that bleeding history. And we'll talk a little bit about the limitations of that in certain populations. Certainly, a 2-year-old may have a very limited bleeding history compared to a 70-year-old. But this, we'll talk a little bit about the role of bleeding assessment tools. So this is where you come in, Jonathan. This is an area where you've obviously done a lot of research. I think it's really critical, the utilization of all these tools that have been put into practice. So can you tell us a little bit about how you use them in your practice and where they may be most appropriate?
Sure. Thank you for that. So bleeding assessment tools have developed over the years, and I think you can see at the bottom of the slide, there's been many iterations moving now to the ISTH BAT and the self-BAT. So bleeding assessment tools are very critical, especially in the primary care scenario, for knowing which of your patients actually has clinically significant bleeding that would warrant a further evaluation for a bleeding disorder, including von Willebrand disease. So looking at the probability of VWD, really the guideline panel recommended that for a patient that's seen in the primary care setting, that the panel recommends using a validated bleeding assessment tool as an initial screening test to determine who may need further testing. And this recommendation is the strongest for adult women who have been evaluated quite a bit by the bleeding assessment tool. There's been a lot of study looking at bleeding symptoms in women in particular. And I would say that in a big picture, these bleeding assessment tools ask different domains, such as, you know, easy bruising, what menstrual periods are like, dental bleeding, bleeding with surgery, things of that nature. And basically a patient's given a score. And if the score reaches a certain threshold, then patients are warranted to have a further bleeding evaluation. Now, depending on where you practice, that may be, you could start the evaluation before referral to a coagulation hematology specialist, or just getting a patient in the door to see us, and we can take the evaluation from there. I think, you know, where the ASH guidelines are actually recommending against doing BATs routinely is once a patient's come to see a hematologist, or once there is, if there's a family member affected by a first-degree relative with von Willebrand disease, then really there's not utility of doing these questionnaires, and that really it's more the coagulation hematologist expertise in what laboratory evaluation to do moving forward. And you can see there different blood tests that are used to screen for von Willebrand disease. We measure the antigen, or the amount of protein, some measure of the platelet-dependent binding activity, and also factor VIII. And those are kind of the bare minimum tests that we typically use to screen for von Willebrand disease. Next slide. So in looking at this, I wanted to highlight that, you know, taking, as Robert said, Dr. Sidonio said, taking a good history is of utmost importance. And sometimes when there's maybe some nuances in the bleeding of your individual patient, they may not have severe von Willebrand disease. They may have what we call low VWF, or mild type 1 von Willebrand disease, where their levels may be in the 30 to 50% range. And this nice study by our colleagues in Ireland, Dr. Lavin and her colleagues, looked at bleeding in low von Willebrand factor, and actually showed very nicely that the bleeding was actually related to having von Willebrand disease and not due to having some other concomitant hemostatic abnormality. So really, you know, even patients that maybe per the old criteria before the updated 2021 guidelines may not have met a strict criteria for von Willebrand disease, but had low VWF, you know, now if patients have low VWF and significant bleeding symptoms, we are categorizing them as having truly type 1 von Willebrand disease. And I think you can see here in the slide a variety of bleeding that we've already mentioned: dental, heavy menstrual bleeding, and moving into more minor bleeding, easy bruising, et cetera, are a lot of what our patients come to see us for in clinic. So it's really just kind of highlights from a primary care standpoint where you can begin in your evaluation for a patient having a bleeding disorder like von Willebrand disease.
So that's great. So perfect timing to move to our case study. Let's get the audience involved in this case study. So this is patient's name is Daryl, and he's a 9-year-old male with a personal history of bleeding. You can see they're listed below. He had nosebleeds requiring cautery. He had some easy bruising, no really early life bleeding. He didn't have any prolonged skin bleeding. And of course, he's 9, like most 9-year-olds have never had a surgery. He did have some oozing with dental extractions that required some good old-fashioned tea bags and some repacking. And there's no family history of bleeding disorders, and he presents to his primary care physician. So remember, the setting is primary care. And so as a primary care physician, how should Daryl's PCP evaluate his bleeding? So here are the answers listed here, and I'll read them briefly. So should he use a bleeding assessment tool? Should he just refer to a hematologist? Should he order genetic testing evaluating for any variants in the VWF gene? Or is the bleeding listed there really not severe enough to warrant any kind of evaluation and shouldn't be evaluated? So go ahead and vote now, and we'll wait a few minutes for the answer. So remember, this is a 9-year-old with a personal history of bleeding, no family history of bleeding disorders noted, and he's at his primary care doctor and reporting the certain bleeding symptoms that we listed below: dental bleeding, nosebleeds, and some easy bruising. All right. So most of you don't even need this presentation, I guess. So the answer is listed here. The majority of you got this right. You should use a bleeding assessment tool. And as Jonathan just elaborated, in the guidelines, the pre-test probability is quite low when you see a patient in a primary care setting. And so you should use the bleeding assessment tool to decide whether further bleeding is needed. If he's already referred to Jonathan or myself or Miguel, then you can use the bleeding assessment tool, certainly a good way to get bleeding symptoms. But at that point, the evaluation should just be done. And certainly if he had a sibling, it's about a 50-50 chance. And so a bleeding tool shouldn't be used to determine whether further workup is necessary. So I don't know if you have any comments, Miguel, on this.
Yeah, I mean, I think it's very important to be able to have access, to these tools. And I can tell you, even when patients come and already referred to us, I get a bad score on everybody as a baseline and have it in our history. Because I think there's a lot of variability among, sometimes when they get older, it might change their bad scores depending on the treatment. So I always get a baseline at least to be able to, go back always and see how that patient presented.
Sure. Jonathan, you guys have you incorporated the BAT? I know there's the self BAT. Obviously, it can be completed by yourself or it can be administered.
Yeah, I mean, we have done the BAT. It's mostly, to be honest, done in the context of studies because we've been looking to see, as you alluded to, what's the appropriate context in which to use a bleeding assessment tool.
Sure.
So we have a majority of our patients do have a BAT. There are some that do not. And really, I think as of right now, the most important venue in which to use it is for primary care. Certainly, it is a helpful thing to do. Certainly, it can help us as hematologists, as Miguel mentioned. But looking at the data, that's the strongest recommendation, certainly.
Robert, one thing that I think is important is using the score is they get used to asking the right questions when they look at the complete BAT. I think is very important, so they get used to what really to ask, because sometimes that's what happens, they miss certain things.
Sure.
So
absolutely.
I think
Yeah,
is important.
and any, this is something that it can be trained. If you're administering it, you're a nurse, your nurse practitioner, PA, anybody on your team could be using this, and depending on your setup at your clinic, I think you should sort of adapt how you need to. So,
yeah, and I would echo Miguel's point that especially when like training new staff or residents or medical students, helping them, a bat, showing them a bat, how it's administered is a very comprehensive way to get them to think about bleeding symptoms that maybe they don't always think about. So
certainly, yeah, because we always may forget one of those bleeding symptoms, and it helps us. GI bleeding for children, I sometimes will forget. So, all right, let's move it along here. So we talked a little bit about when to test, and the guidelines really get into the actual meat of it, of the actual testing. And you can see here they discuss the different types of testing, as Jonathan mentioned. If the factor VIII level is lower than the VWF antigen, you should consider evaluating for type 2N von Willebrand's. And then there's a number of platelet-dependent VWF activity assays. And from that point, you can see there's a branch point where we focus on what those levels are. When you see VWF levels, that's referring to the antigen, and also one of the functional assays, either typically the ristocetin cofactor assay or the newer GP1BM assay. And we'll talk a little bit about that as well. And it's really important to continue to evaluate bleeding symptoms because this guideline only evaluates for von Willebrand's, and certainly there are people with platelet disorders that you may need to consider. So moving forward here, Jonathan, why don't you go ahead and tell us a little bit about these available screening labs that are listed on this slide?
Sure, absolutely. The ones highlighted there in blue are by far the most commonly done in the US. So as I had mentioned, the von Willebrand factor antigen is simply a measure of the BWF protein level in plasma. So, it screens for quantitative deficiency. Like I mentioned, it's reduced in type 1 and 3. It also is commonly reduced in type 2, but not always, and really just measures the amount of protein, how much protein is actually there, but not the function of how the protein itself works. So you look at the next level of testing, the ristocetin cofactor activity. So this really measures the ability of von Willebrand factor to bind to platelet GP1BA. And it can screen for some of the variants. Also, it can, it's another reflection of the activity, and will also be low in type 1 and 3 von Willebrand disease. But the ristocetin cofactor, without going into too much detail, is a test that has quite a degree of variability, not just within an individual's own lab, but also between laboratories across treatment centers as well. And otherwise, there's other variants such as the D1472H polymorphism that can affect the level, make the ristocetin cofactor level low, with actually not affecting the patient's own von Willebrand factor functioning, so meaning causing a falsely low level where it could erroneously diagnose someone with von Willebrand disease potentially. So an improvement to the ristocetin cofactor assay is one that does not use ristocetin, called the GP1BM, which is a mutated glycoprotein 1B that will measure the platelet binding activity of von Willebrand factor in the absence of ristocetin. This is widely used across Europe and also in Canada. There's limited availability in the US, which hopefully will be changing in the very near future, because if you're looking at the direct measure of von Willebrand factor platelet binding activity to look at its activity overall, it's better to have the GP1BM than the ristocetin. Yes. So hopefully in the next few years that will change. Factor VIII binding is also important to look at its chaperone capabilities of von Willebrand factor to chaperone factor VIII in circulation. It can be low in type 2N and type 3 as well. And then we also look at the ratio between VWF activity to antigen, and this will be off because you think if it's a qualitative defect, typically your activity will be less than your antigen, and this can screen for some of your type 2 variants. So in looking then, with it, certainly others can go to the guidelines to look at the kind of diagnostic algorithm in more detail. But there are a stepwise approach if you do have a reduced ratio and considering type 2 von Willebrand disease, do other tests like von Willebrand collagen binding, looking at multiple analysis, looking at patients' response to DDAVP, which we'll talk about further in this presentation, and can further refine the diagnosis of von Willebrand disease. So really, this is a slide that's pretty comprehensive in the different type of confirmatory tests. Just in brief, I'll mention other things like I mentioned collagen binding, von Willebrand factor collagen binding. There are specific defects of just a collagen binding defect with other laboratory tests being normal that sometimes can be clinically relevant. Looking at von Willebrand factor multimers, so that's looking at how von Willebrand factor forms that long ladder. I always talk to my students and residents about von Willebrand factor being like Velcro. So if your piece of Velcro is not long enough, you can have abnormalities in how von Willebrand factor binds. The platelet binding activity, which can screen for an enhanced binding, which would be suggestive of type 2B von Willebrand disease, as well as the ristocetin-induced platelet aggregation, which is another way to get at the platelet binding of von Willebrand factor and looking for a variant. And then looking for factor VIII von Willebrand factor binding to look and see if there's type 2N von Willebrand disease. This is important to do, especially in someone who may have mild hemophilia or type 2N. This can hash out if their 2N if their factor VIII binding is low, then it's a type 2N von Willebrand disease rather than mild hemophilia. Propeptide is another means to look at increased clearance, which is type 1C von Willebrand disease. And then finally, gene sequencing, which has limited diagnostic utility, but it can be very important, especially if you have a variant von Willebrand factor, because there are more than 1,700 different sequence variations cataloged to date. And so this is really reserved for more unique situations that an expert coagulation hematologist should be looking at. In regards to the propeptide, though, I think, Robert, there was a recommendation from ASH guidelines not to do that routinely in clinical practice, correct?
Yeah, and I think we talk a little bit about that a little later, but this ratio is a nice, easy way of doing this. This testing is typically required to send to specialized labs, and we'll talk a little bit about the role of DDAVP challenges, right, which may be a little easier for most people to utilize, and actually will give you clinically appropriate information.
Sure. So, in moving forward, this is just to highlight, some research that's been done in the area. So I did develop an all-encompassing multiplex activity assay, really to look at all of those different tests that I mentioned on the previous slide, to look at variants and discriminate their variant in a one-stage assay. So this is just to highlight, in our particular study, we looked at a cohort of patients who had von Willebrand disease, either variant or non-variant. And this assay overall, just kind of cutting to the chase at the bottom of the slide, over 88% accuracy in correctly assigning the variant of von Willebrand disease phenotype. So this is just to highlight that in the future, there may be a little bit more refinement in the diagnosis of von Willebrand disease. And certainly, myself and our colleagues across the world are endeavoring to try to simplify, making a complex diagnostic process for a very common bleeding disorder more refined.
Certainly. So more to come in the future on that. So, all right. So let's move on. Thank you very much for the insight on that first learning objective. Let's move on to our second learning objective, which focuses on the individualization or individualizing the management of von Willebrand disease. All right. So Miguel, we know you've treated a number of patients in your career. Why don't you walk us through sort of the basic ways that we control or prevent bleeding in patients with von Willebrands?
Yeah, as you previously mentioned, knowing the pathophysiology of von Willebrand disease, so we need to, look at, what is our goal with the treatment? And our goal is really to improve platelet adhesion and aggregation, right? To get to fiber formation and maintain a stable clot. So there are pretty much two ways that we can do this in patients with von Willebrand. And one of them is by stimulating the release of endogenous von Willebrand stores. This is when we use, for example, desmopressin. Or the other way is by increasing the plasma concentration of 1 milligram, either utilizing a human plasma-derived virus inactivated concentrate or using a recombinant 1 milligram concentrate. I mean, certainly we do have adjunctive therapy, different agents that we use to promote hemostasis, like antifibrinolytics, and we can also use, other strategies to be able to increase our levels. Like, for example, in the females, hormones can be used, estrogens, that could also be quite helpful. So we will be, treating pretty much 3 different scenarios. One is an on-demand treatment, meaning treat when the patient has a bleed. The other one will be to utilize our treatment scenarios or our treatment regimens when the patient is going to go for surgery. So to prevent, let's say, excessive bleeding in those individuals. Well, now, more recently, we've actually been using prophylaxis in patients with 1 milligram, very similar to what we've been doing, for many years for patients with hemophilia. So here in this table, we have at least an example of the different treatment options. As I already previously mentioned, you got those patients with low 1 milligram, not necessarily being diagnosed with type 1, but definitely have low 1 milligram and have symptoms. So we can easily use desmopressin in those individuals. It can be used IV, it can be used intranasal, although it's been somewhat difficult to find now lately. And you see the different dosing that it can use. Subcutaneously, I guess it could be used. I don't have a lot of experience with the sub-Q desmopressin. Now, for the type 1 patients, for the majority of them, you can also use the desmopressin, if you're going to treat maybe some minor bleeds. I mean, we do have type 1s that have very low levels. In my practice, I usually go straight to replacement products. Now for the type 2s, most of the time we use 1 milligram concentrates, either the plasma-derived or the recombinant product, but you could possibly use desmopressin, for those type 2A. And definitely for the type 3s, desmopressin and most likely is not going to work. So definitely the use of the 1 milligram plasma-derived or the 1 milligram concentrate. Now to the right, we have the antifibrinolytic therapy. As an example, we here have tranexamic acid. It could be used, 3-4 times a day. It could be used IV. It could be used by mouth. But we also have aminocaproic acid as well that could be used quite similar. So it's not unusual to have, a dual kind of treatment. For example, a patient that undergoes wisdom teeth extraction. Not uncommon that they get either desmopressin with tranexamic acid or aminocaproic acid, or depending, on their phenotype, they can get a concentrate in addition to an antifibrinolytic as well. Now, with regards to the desmopressin for 1 milligram, remember desmopressin, the mechanism of action is just triggers the release of 1 milligram and factor VIII from the endothelium storage sites. Just remember that desmopressin could sometimes produce some symptoms to patients in terms of adverse events. You have to monitor sometimes their electrolyte, especially sodium, make sure because they can get hyponatremic, especially if they're drinking a lot of free water or if they're using it quite frequent. We usually, at least in our practice, we recommend using it, maximum 3 times, probably over 72 hours or every other day. Sometimes they can use it, especially the females during their periods. We usually recommend doing a trial of desmopressin because not all the patients respond adequately. Those individuals that have levels between 30 and 50, what we call the low levels of 1 milligram, we assume they all respond. But I usually got into the habit of doing a trial on everybody. Now, and those individuals that have levels below 30, the true type 1s, I usually recommend doing trials in those individuals as well. And I'm sure, you guys might have do something similar in your centers. Now, for those individuals that have the type 2s, they might not have a great response. And we definitely don't use it in the type 2Bs, mostly the type 2As. The response might be partial or much shorter response. So maybe for something very minor, but in my practice, I go straight usually to factor replacement. I usually don't like to waste time, and definitely in the type 3s, I go straight to the factor replacement.
Yeah, that sounds great. So Jonathan, do you have insight. Obviously, we don't typically use it in type 2B, and there's no reason to use it in type 3. Do you typically undergo trials? I think a lot of us have done this until recently. The guidelines say you don't absolutely have to do it from 30 to 50. I think it's sort of been a habit for most of us to consider a trial.
Yeah, I mean, I think the as you mentioned, the literature does suggest that, especially in mild type 1s or low BWF, it may not necessarily be required. However,
Sure.
I still have myself, probably just because of the volume of patients that I treat, but I have some patients even with low BWF that do not respond well to desmopressin.
Sure.
The other caveats to think about, as Miguel mentioned, the hyponatremia. Certainly in the very young, my practice has been under 2 years of age, especially, when very young children have increased total body water and more difficult to limit fluids.
Yes.
We tend to not use it as often. We would go straight to concentrate as well. And also on the flip side, I also think about, patients that may have cardiac risk factors. Like
Sure.
I personally get a little bit squeamish if I have a patient who's around 60 years of age, hypertension, maybe other cardiac risk factors. And so in that regard, I'll also go straight to concentrate. But certainly I think that a Ddavp trial is an important thing to do. I like Miguel would likely not use it in variant von Willebrand disease. I think I may have used it in a few 2Ms where it's been efficacious in conjunction usually with, let's say they have their wisdom teeth out, they may get some concentrate before a procedure, and then they do intranasal Ddavp at home, post-op day 1 or something like that, along with antifibrinolytics. So it does offer that benefit of home therapy, especially in patients that aren't used to, intravenous administration of concentrate, or that may live a little bit farther away from the treatment center, so they can't come and get infusions as readily.
Yeah, that sounds great. So in certain situations, obviously, like we just discussed, replacement therapy is the only option, or it could be a combination with desmopressin. Miguel, can you take us through this? And we had to list brand names here, obviously, because it's important for people to understand the differences in half-life, regulatory approval, and of course the ratios.
Correct. Here in this table, we just have an example of some of the products that have been approved for the use of in patients with von Willebrand disease. And Robert was saying, you can say we got two categories. We got the plasma-derived that are virally inactivated, the first 3 products, and then we have a recombinant von Willebrand product that most recently got approved. And in those, products that are plasma-derived, we see that they have both von Willebrand and they have factor VIII. So they're going to have different ratios, and they're not the same. So you have to, kind of get an idea of what you're going to be using and what you want to use it for. But you see the ratios vary from some of them going from 1 to 1, and some of them going to even greater than 2 to 1. So you have to be aware that there are differences among these products. Now the half-life, again, it's going to be somewhat variable. For example, of the half-life of von Willebrand is going to be anywhere from 8 hours to maybe about 15 hours, depending on the product. And the half-life of factor VIII is going to be anywhere from 12 to probably 18 or 19 hours as well, which is here seen in the middle column. Now, if you look at the last column on the right, the regulatory approval, you see that none of them have been approved for prophylaxis. This is something that more recently, I think we're starting to do in our practice. But the majority of them are being approved for surgery and certainly for on-demand for these products.
Sure.
Now, in terms of, what is the dosing, what target levels do you want to do? I mean, this is something that is going to be quite variable, and I think we learn by experience. Certainly
Sure.
There are a lot of guidelines and ways maybe to do this, but I think in general, if we have a patient, let's say if you want to treat him on demand, meaning you're going to treat him when he has a bleed, if it's a mild to moderate bleed, if you're using a von Willebrand concentrate, you can give a dose anywhere from 20 to 40 units per kilo. What are the target levels you want to stay? Maybe a peak above 50, somewhere between 50 and 80 in the first day, and then your trough level can be greater than 30 after day 1. If it's a mild to moderate bleed, most likely you're going to treat that patient for 1 or 2, maximum 3 days. Now, if it's a severe bleed, we definitely like to go with a higher dose, somewhere close to the 50 unit per kilo. Want to have that big peak, and for that initial bleed, probably it's going to be greater than 100, at least in the first day. And then you can keep troughs around 50 or a little higher after day 1. And the treatment is going to vary depending on the severity of the bleed, anywhere from 7 to 10 days, depending on what it is. Now, if you're going to take a patient to surgery, if it's a very uncomplicated procedure, maybe a single dose of 25 unit per kilo might be enough. You'll get a nice peak over 50, and you're done with that patient. Now, if it's a minor surgery, usually 30 to 60 unit per kilo, keeping peaks of maybe a little bit over 50 to 80 on day 1, and then troughs of about 30. And again, the number of days is going to depend on the treatment. And if it's a major surgery, let's say you're going to undergo a knee replacement or a big abdominal surgery or something like that, then we go with a higher dose, 50 to 60 unit per kilo, having a high peak of greater than 100 in day 1, and having those troughs at least about 50. I usually do at least for a couple of days, and the treatment again is going to depend on the type of surgery that individual undergoes.
So, this is a great point. When we're taking care of patients, and certainly at our center, when we're getting ready for a procedure, there are a lot of other healthcare members, members of our team that are involved in this, coordinating it. And so I know our nursing and nurse practitioners and PAs often are really critical in making sure everything is done correctly. Everybody is emailed, and plans are in place in the chart. Is that similar situation, Jonathan? Can you talk a little bit about the other members that I may have left out as well that help to make sure the coordination, in and outpatient?
Yeah, it's absolutely critical, and I think that's an important reason to have a multidisciplinary care team, at the treatment centers. So, yes, our nurses are in close coordination with, the pre-op and post-op nurses, with the surgical teams. We draft treatment letters with recommendations for, if it's inpatient management and also out for outpatient management. And we also, if a patient's going to be inpatient, we will follow levels, von Willebrand Factor levels in the hospital setting. Usually we tend to monitor von Willebrand Factor and Factor 8 levels, just depending on a surgery. For example, like say a woman with more severe von Willebrand disease that's gonna deliver a baby. We would make sure that we had third trimester laboratory studies completed to see what her rise is, and then coordinate with the OB team for appropriate treatment, and then following those postpartum levels as they drop off, and treat with antifibrinolytics at the same time. So it's definitely a lot of moving parts, and I think making sure that our colleagues, outside of hematology, whether it be ENT, OB-GYN, general surgery, dentists, et cetera, that they're aware of our treatment plans, and that they're comfortable and keeping close communication with our team, so that we can ensure the patient doesn't have any unexpected bleeding complications.
Yeah, that sounds great. And so let's, I see a lot of questions building up there, so let's keep this moving here. So let's talk about surgery now with tranexamic acid, also commonly known as Listeto in the oral preparation. So we talked about minor procedures, and the guidelines really weighed in on this. And so they suggest, so not a strong one, that increasing the levels to greater than 50 with desmopressin or factor concentrations with the addition of tranexamic acid. So this makes sense. This is pretty much what most of us have thought about, and Dr. Escobar just mentioned about doing the desmopressin with factor concentrate. Where it gets a little bit difficult and a little bit different than some people's practices is they suggest using tranexamic acid alone over increasing levels greater than 50 for certain situations. So minor mucosal procedures, so maybe minor dental work, maybe not wisdom teeth extraction, but maybe one cavity, mild bleeding phenotype patient, or in somebody that has levels greater than 30, so those in the 30 to 50% range, you could consider giving tranexamic acid alone for these minor procedures. And certainly for those that are higher risk for thrombosis, avoiding those prolonged exposures, as mentioned before, in which the factor VIII levels may be in excess of 150 for more than a few days. In these situations, you may want to reduce the extended use of tranexamic acid. So really trying to dial in the dosing where it's just high enough, but not too high. So one great thing about the guidelines is they really honed in on specific patient populations and scenarios. So heavy menstrual bleeding, pregnancy, and aging. And really, this has been very helpful because these are common scenarios. These are things I'm sure everybody that's listening has encountered. And we did try to address many of those. So let's take each one of those. So first, heavy menstrual bleeding. Well, we decided we wanted to really define it in a way to make it straightforward. And there's a definitions paper that accompanies these guidelines. And so it's very simply menorrhagia or heavy menstrual bleeding, bleeding that lasts at least 8 days, consistently soaking one or more pads or tampons every 2 hours on multiple days, requiring the use of more than one item, so a pad and a tampon at one time, changing it if you have to get up in the middle of the night to change it, passing large clots or clots the size of a grape, and then having a score, if you see there listed, it's a semi-quantitative assessment, bleeding assessment score of greater than 100. And we put a link on here with a reference to a website that was involved in this one. And so I'll pause here briefly just to see, we talked about it before, but at least half of my patients, and probably my trainees feel like it's probably 75% of my patients, heavy menstrual bleeding is extremely common. And it's a very common scenario in which we diagnose a patient. I'm assuming the same scenario with you, Miguel.
Yeah, absolutely. I think this is one of the most common, certainly consults that we see, mostly in the outpatient, coming from primaries, coming from
Sure.
internists, coming from OBs. So definitely, I think is important. And it's something that, sometimes we just don't feel comfortable talking about, asking our females, how are your periods, how heavy they are, you got to go into the details.
Yeah.
Because, most of them will tell you it's normal, but they don't know what really normal is, because their mom was the same way or its sister is the same. They think it's normal and they're bleeding excessively. Yeah. So I think this is very important.
Yeah. And Jonathan, I'm assuming, you have trained your trainees to make sure you get that question, not just are their periods heavy or not, because you may get a short answer.
Yes, absolutely. I mean, as is outlined here on the slide, we ask essentially all these questions, and as was as yours and Miguel's experiences as well. I mean, this is profoundly common consult that I get. I mean, multiple patients every week. The other thing I would say is even sometimes I'll be referred patients for iron deficiency, and then turns out no one's taken a good history, and then I'll diagnose them with von Willebrand disease and treat their iron deficiency. So it's another thing that should really go hand in hand for us taking care of women with excessive heavy menstrual bleeding, is to look for that iron deficiency, because it's undertreated and it causes symptoms, it causes morbidity, fatigue, and difficulty with school performance, et cetera. And it's really easy to treat, and oral and IV preparations are great. And so I would say that's probably the largest impact I see. But it is very common in practice, especially among women who have von Willebrand disease.
Yes, definitely. So good advice. So let's move on and see what the guidelines had to say about heavy menstrual bleeding and von Willebrand's. Well, the panel suggested either using a hormonal therapy, so that could be an IUD or combined oral contraceptive, or potentially a progestin only, or tranexamic acid. And this is over desmopressin to treat women with von Willebrand's and heavy periods. And this is specifically in the population that is not interested in having children. So these are all your teenage patients or women that do have no desire or do not wish to conceive at this time. So obviously starting them on birth control pills would prevent pregnancy in most situations. And so it makes sense. And so it's really important that we consider hormonal therapies in this population. It may not work for everybody, but at least consider it, or Lesteta or tranexamic acid. And the panel suggests using tranexamic acid over desmopressin to treat those that wish to conceive. So obviously not using some hormonal method if they want to conceive. And it's really important to understand that prophylaxis could be used as well, case-to-case basis, certainly is a second-line therapy, or if patients aren't able to tolerate or it's contraindicated to give hormonal therapy. All right, so let's get on to the second case study now that we've discussed heavy menstrual bleeding here. So this is Shayna. She's a 25-year-old, and she is planning to conceive. She's been followed at your center since age 10 for heavy periods. And in that setting, a diagnosis of type 1 was made. She has heavy periods with flooding. They last more than 7 days, some easy bruising, and then maybe a little bit of bleeding after her tonsillectomy. So pretty classic case. You can see her labs there. They're in the 30 to 50 range, mostly in the 40s. And certainly her PBAC score is elevated. All right, so let's talk about the treatment of choice for managing her heavy periods. So the options are here: intranasal DDAVP, TA or tranexamic acid, VWF concentrate, or a pharmacologic treatment is not recommended. It's a little bit of thinking music here. So think about this point in her life where she is planning to conceive. What is the treatment of choice? So that makes sense. So, hormonal therapies wouldn't be an option. Certainly tranexamic acid is the correct option, because this was not going to have an effect on fertility in any way. And generally, desmopressin we'll talk about isn't recommended as the first line. Certainly could be an option in some patients. And so for the sake of time, I'm going to move through because I want to make sure we get to all these questions. We certainly have a lot that are building up here, which is great. So let's talk about those special populations. We talked about heavy menstrual bleeding. Now let's talk about pregnancy and delivery. And this was addressed. There's very limited data, but what they had, they are able to make reasonable suggestions here. And so during childbirth, women should have their levels of at least 50 immediately prior to delivery. And it's really important to understand that majority of women with mild type 1 will have levels over 50. And these levels should be maintained for 3 to 7 days. Certainly there are types like type 2B where it may get worse, platelet count may delay. And it's really important to really surveil for delayed postpartum hemorrhage, These kind of things can interfere with breastfeeding, certainly cause significant anemia, exacerbate issues following delivery. And for women who are having neuraxial anesthesia, so epidurals during labor, they suggest targeting a level of 50 to 150, and then overusing a very high target level. So there doesn't seem to be any data. And certainly if you're concerned, targeting closer to 100 is totally reasonable. And it should be kept at least for 6 to 12 hours after it's removed. And then to prevent postpartum hemorrhage, the panel suggests the use of TA over not using it at all in women with type 1 or low VWF. These are really good options to prevent postpartum hemorrhage. It's been extensively studied. And so this is where there is pretty significant amount of data. And just very briefly, are these strategies that you typically are utilizing in your patients? It sounds mostly they're referring to milder patients, of course. We'll start with you, Miguel.
Yeah, this is pretty much what we do in our practice. Definitely, it is quite common. These ladies going into delivery, and you have to be prepared because many of them might be ready to they're going to go vaginal. Something happens and they need to switch to a C-section.
Sure.
So you need to make sure that what are your different plans in this scenario. But yeah, for example, for epidurals, if we can, my goal is usually above 80 or so to keep it. If it's not, I usually do not recommend doing epidurals. So it is not easy with the severes or sometimes some of the type 2s or very low type 1s. And we use actually a lot of tranexamic for our deliveries as well, and factor replacement if needed.
Sure. Jonathan, briefly, are you using the same strategies generally for this?
Yeah, we're using the same strategies. I think, like Miguel, I tend to target closer to 100. That's just my clinical practice.
Totally
But also,
reasonable.
yeah, but I think, TXA, using tranexamic postpartum is important. We usually use it for 2 weeks postpartum, which actually,
Sure.
there, even outside of von Willebrand disease, there was a recent study in the New England Journal that showed that was beneficial for preventing postpartum bleeding in women. So we use that. And then also, I would just say another caveat is that delayed bleeding.
Sure.
As levels reach back to baseline after, towards day 7 postpartum, even if your patient doesn't have bleeding initially in the first, day or two, still be mindful of monitoring their lochia and making sure that you're treating excessive bleeding as it develops.
All right, great. So last slide before we finish up this objective. So the other population was aging, probably the most controversial part here, and there may be some questions associated with this. The question, like what we have with young children, can you age out of asthma? And we've wondered, can you age out of von Willebrand's? And certainly there are patients that have low VWF, that the levels become normal prior to me transitioning them to the adult clinic. And so we did talk about this. The panel suggested reconsidering the diagnosis as opposed to just removing it. So really assessing their bleeding risk. Certainly patients with levels that have normalized, they have little to no bleeding. It's reasonable to do a course in which patients may have procedures or are managed without anything. And then you may tell the patient to return if they have more bleeding symptoms. And certainly retain those that don't, the bleeding symptoms don't seem to get better. And on the flip side, we talk about managing those as you get older. Just because you have von Willebrand doesn't mean you can't have cardiovascular disease. And they commented on this as well. Those with von Willebrand's and CVD who require treatment with antiplatelet or anticoagulation therapy, the panel does suggest giving that needed antiplatelet or anticoagulant therapy over not doing anything and assuming their von Willebrand's will protect them. Obviously, reassessing multiple times, and then really being very careful about desmopressin. This is a population, as Jonathan mentioned, where you don't want to increase the risk of thrombosis. So let's move on to our third objective. I see more and more questions coming up, which is great. Probably one of the more interesting things, and we'll talk about long-term prophylaxis. And it's really important that this is off-label, but there's some emerging evidence, and I think it's reasonable to talk about what we're doing in clinical practice. So we're going to talk about evaluating the evidence for long-term prophylaxis in patients with von Willebrand's. And so I think this is where we're all going to talk a little bit. I'll make a few comments, and certainly I'll let you guys jump in. But you can see here, we always are balancing the benefits versus the barriers. Certainly in von Willebrand's, as you can see here on the timeline, there have been significant innovations in hemophilia. And particularly in the last 15 years, there's just been an explosion of new therapies. And there has been a recombinant VWF concentrate recently. And so there hasn't been as much innovation. Certainly it may be because a lot of patients are not on prophylaxis, and a lot of patients may not have good venous access. They may not have the skills to do prophylaxis, and they may not see that there's a benefit. So I'll let you start out, Miguel. This is something we're always talking about, and it's certainly evolved over, I'm sure, your career as well.
Yeah, I think we can, as you said, we can probably learn a lot from hemophilia. In hemophilia, we've been doing prophylaxis, I don't know, for many decades now, and certainly we know it works, right? So I think in von Willebrand, we've been, like you said, quite maybe slow to take off and be aggressive in their management, because I can tell you, I have women which they get, we can call prophylaxis just during their periods, and they do great. They're really happy now knowing that their bleeds can be controlled. Sometimes they don't respond to the hormone, to the antifibrinolytics, and just by giving prophylaxis 3 times, 3 days of their period, it's a huge difference. So, and I think, once you start prophylaxis, certainly comes all the different barriers about I guess you can put it as a chronic treatment, right?
Sure.
That we can see here on the table.
It's not for everybody. Yeah.
But I think you have to take every patient individually and make an assessment and see what their goals are, and then go from there and offer the different, treatment regimens that we have available, which one of them is prophylaxis.
Sure. Jonathan, you want to add anything about prophylaxis? Obviously, this is an emerging, topic.
Sure. Yeah, I think a lot of it too in von Willebrand disease is the patient culture, because for many decades now in hemophilia, that's been the culture that prophylaxis is the standard of care. And I think that there's a couple things in von Willebrand disease. There's not as many patients, or I should say, there's more patients that are not diagnosed, and so they may come to us later in life. So they may doing something like intravenous access can be a bit of a personal barrier in wanting to do something like prophylaxis. But I think also it's probably the clinicians that just haven't brought it to the forefront, like some of our European colleagues that I think have been much more adoptive of von Willebrand prophylaxis than we have here in the US. So I think it's something that I have in the recent years, like maybe the last 5 years, brought up earlier with my patients, letting them know that there is something we can do besides just tranexamic acid or just the Ddavp at home. That may not be as efficacious. And like Miguel said, I also have patients that for their periods, they come in. I've had some that are having a particularly difficult time with epistaxis that we do prophylaxis. And then certainly some of my more severe von Willebrand disease patients with gastrointestinal bleeding, joint bleeding, like in hemophilia. And those patients have been on prophylaxis for many years. So I think it's something that we need to raise awareness from a clinician standpoint as well, and then help to shape that patient culture to know that, hey, this is something that is available and can be beneficial in helping you live a life with reduced bleeding.
Certainly. So to that end, the guidelines panel decided to weigh in on prophylaxis. And it seems like a fairly benign statement. In patients with VWD with a history of severe and frequent bleeds, the panel suggests using long-term prophylaxis over not doing prophylaxis, and then periodically assessing bleeding symptoms. But that statement was actually pretty good. If you look at their original guidelines, they don't even talk about the role of long-term prophylaxis. When they use the term prophylaxis, they're typically referring to treatment before a bleed. I think it's really important to point out what's not in the statement. So you don't see subtypes listed here. So is it just for severe type 1 and type 3? It really focuses on the bleeding symptoms and the recurrence of them in an effort to improve quality of life. And so to that end, Jonathan alluded to this, we do need to do more studies in this. There's been a long-standing history. Hemophilia has done great studies over the years, as Miguel alluded to. So we're going to talk about 2 recent phase 3 clinical trials that give us some data on long-term prophylaxis. And Miguel, why don't you start us off with the first one that focused on recombinant VWF? I think you're on mute, Miguel. Sorry.
Sure.
There you go.
I'm just going to be brief since this is preliminary data, but this is a phase 3 prospective, open label, non-randomized, but it's a multi-center study looking at prophylaxis, where a specific product was a recombinant Willebrand factor that was used in patients with severe von Willebrand disease, and they have very strict criteria. And the objective of this study was to look at efficacy and safety of this product using prophylaxis in adults again. And you can see here to the left, we got, they were able to get historical information from those individuals. There were a group that were on demand, and then a group that was on prophylaxis with a plasma-derived product, the switch, which called the switch arm group. You have here a total of 23 patients. Now, if we look to the left, the time period, you see those historical numbers, of spontaneous bleeding events. You see they're quite high, and the prior on-demand 200 and the switch arm 50. Now, when we looked at on study while receiving prophylaxis with the recombinant von Willebrand, we see the number of treated spontaneous bleeding events in the on-demand was 9, and the switch arm was 18. Now, overall, if we look at the comparison, on study versus historical, what is that percentage of change? We see that in the prior on-demand, there was a 91.5 reduction in bleeds, and in the switch arm, there was a 45% reduction. Now, a secondary efficacy analysis, they looked at the spontaneous ABR intra-patient comparison. We can see here on the right, the two graphs, the spontaneous ABR reduction success for all types of von Willebrands on the on-demand group was 92%, and the type 3s was 90%. And then for the ABR, spontaneous ABR in the prior prophylaxis was for all types 90%, and for the type 3, 88%. So as conclusions from this study, you can see that recombinant von Willebrand prophylaxis was quite effective in reducing spontaneous ABR in patients that were previously treated on demand, and they were on plasma-derived von Willebrand that got switched, to a recombinant product. Now, in regards to the individuals that were on the prophylaxis previously, they were able to maintain the same level of hemostasis control in those individuals when they compare them to the ones that switched. But definitely there was a huge difference from those from the on-demand group.
So yeah, so great. So it showed that it was efficacious, that there were no serious adverse events and no.
Right, no, there were no serious adverse events, no thrombosis, no antibodies that we're always concerned about.
Yeah. So great. So not large numbers, but they're really, these studies are very difficult to conduct. For sure. So the next trial was done in Europe, and I'll let Jonathan walk us through this poster.
Sure. So this is a phase 3 study looking at secondary long-term prophylaxis versus on-demand treatment, this time using plasma-derived VWF factor VIII concentrate in severe von Willebrand disease. And really their objective was to evaluate if prophylaxis with concentrate was effective in preventing spontaneous bleeding in patients with severe VWD that was unresponsive to Ddavp when compared to on-demand. And so you can see this was also 12-month international multi-center randomized open label trial. And you can see, again, the numbers here very small in on-demand versus prophylaxis. A majority, a type of bleeding like we've been talking today, mucosal bleeding, joint and muscle bleeding and more severe, and also some gastrointestinal bleeding. And you can see the number and incidence rate of bleeding episodes during the study were organized in these treatment groups. Again, it's important to note that there are no clinically significant AEs attributed to the study medication throughout this. And if you look over at the right side of the slide, you can look at the on-demand versus prophylaxis, that the probability of remaining free of a first spontaneous bleeding episode was improved for those that were on prophylaxis. So really this study's conclusion was that the prophylactic use of von Willebrand factor VIII concentrate appeared to be associated with a lower risk and frequency of bleeding episodes in severe von Willebrand patients. And again, these were those that were unresponsive to Ddavp. Although, more data is needed for gastrointestinal bleeding based on this study. So again, just another publication giving us more to discuss with patients when considering prophylaxis. I mean, I think in my clinical practice, whenever I bring up studies, a picture paints 1,000 words. And so sometimes, reviewing some of the data that we have, emerging data for prophylaxis and VWD can be beneficial when making the argument that it may be efficacious for the patient that's having bleeding problems in front of us.
Yeah, that's great. So 2 great trials. And let's talk about one more trial here that's ongoing. So this is the Athens 9 study. It's being conducted by the American Thrombosis and Hemostasis Network. I'm one of the PIs, and Jonathan's also involved in the study, as well as my co-PI, Angela Wyand. And this one really is, it's a different type of study. It's a longitudinal observational study. And really the focus is looking at the safety of these treatment regimens, specifically for those with what we're calling clinically severe von Willebrands. And there will be an extra focus on prophylaxis. And you can see here, there's about 80 or so patients that have been enrolled. The majority are Caucasian, as expected with this disorder. And we have people as young as newborns and as old as 75 plus years of age. We currently have about 28 on what we're calling continuous prophylaxis, and 8 of them that are on menstrual bleeding prophylaxis, as Miguel alluded to before. And you can see the dosing there for recombinant. It looks like it's about twice a week. And as expected for plasma-derived, because of traditionally the regimens have been about 2 to 3 times a week. And so since we have very little data, we're really just going on what we've seen on the clinical trials. So this study's got a few more years before it's left completed, but more studies coming soon. So let's, don't want to minimize the role, but obviously it's really, really important that we talk about the team approach. We've already talked about it a few times in this. It's a patient-centered approach. The patient's in the middle here. We have a number of people involved: nurses, pharmacists, gynecologists, sometimes primary care providers. We have physical therapists, social workers, and of course the hematologist, nurse practitioners, and PA. So I know when we have our clinic in our children's hospital, it's an army of people that are taking over the clinic room. And so I'm assuming it's the same. I think, we've certainly have figured this out in this disease state compared to others. I'm assuming it's the same for you, Miguel. I know I visited your center in the past.
Yeah, I mean, I cannot make enough emphasis on this part, but because I think that you could have, in your hospital, the best surgeon, all the products, your laboratory, but if you don't have the right team,
Sure.
The possibility of that success, I think, is not great, and
Sure.
that's why it's so important to be able to,
Sure.
these patients get seen, with all the different specialties, because we have learned from hemophilia already for years doing this, and that's the best model, I think, right now that really take us to success.
And Jonathan, I know you have a similar approach and feeling about this team-based approach.
Yeah, absolutely. And I think, we've even gotten to the point where we're, like you mentioned, heavy menstrual bleeding is a very large population of patients. So we have, like I know you do as well, women's focused clinics where we have women's healthcare providers alongside our comprehensive care team, physical therapy, pelvic floor dysfunction, many other things that are taken care of comprehensively for the patient. So yes, the thing is you need to have a great degree of preparedness
Sure.
in managing complications that can arise. So yes, a multidisciplinary approach is essential.
And that's just the coincidence that the hematologist looks like Dr. Escobar here. So moving up, we're finishing these slides up. So, just as a summary, you should use validated clinical assessments, laboratory tests to accurately recognize, screen, refer, and diagnose patients with a suspected bleeding disorder. It may not always be von Willebrand's. You should be thinking about it, of course. Optimizing patient outcomes by proactively incorporating a team-based approach, focusing on the individualized care of that patient. Same thing we do with hemophilia. We should do the same for von Willebrand's. And certainly using the guidelines. If you read the guidelines, it's very clear this is not the standard of care, but there are strategies that you should consider to accurately identify patients or candidates for long-term prophylaxis in patients while trials are currently being conducted. And so we finish up here, and hopefully we have a little bit of time here to ask questions. Select Ask Question tab below the slide viewer. Many of you have already done this, and include the member's name if you need a specific response from somebody. And so we've actually received a number of questions already, and I think we'll go ahead and take those questions at this point. All right, so let's take those questions. Let me just pull them up here. So the first one here, and I'll just call somebody out on here. Drug shortages are frustratingly common, believe me, in the pharmacy world. How should you handle a shortage of intranasal DDAVP? Are injectables my only option? I know Miguel mentioned he isn't using a sub-Q DDAVP. Do you want to weigh in on this one, Jonathan?
Yeah, I think most of our patients, we have switched to using von Willebrand Factor concentrate. I know there are some providers and patients that are very partial to DDAVP, but our strategy has really been just to switch to VWF concentrate. And certainly for times when you need a precise measurement, even within the same patient, the DDAVP response can be variable. So we tend to have used concentrate. I think through various mechanisms, the intranasal DDAVP is becoming available. So hopefully that will be over shortly. I know our European colleagues have used sub-Q quite a bit. It's, I think, limited in practice here in the US. And certainly it can be used also in an inpatient setting using like the IV form, but I don't know. In my mind, I use VWF concentrate if I'm going to give an IV medication. So
yeah, yeah, and certainly those are ones that it's difficult to give sub-Q, and so let's take some more questions here. The VWF concentrate products differ in ratio. And so which one do you prefer? As a pharmacist, I would prefer the one that has a 1-to-1 ratio. That may limit prescribing errors. We're not always the ones prescribing it, right? Is there a benefit of not a benefit of having the 2-to-1? So a couple of questions there. Miguel, you want to start us out on there? Do you have a preference, or I'll let you answer that.
I mean, I think there are a couple of things here. One is certainly what product is available in your institution, right?
Sure.
Because sometimes you don't have control over
Exactly.
that. But if you do, I think a lot has to do with what their baseline levels are of that patient. You know, the von Willebrand levels are quite low. I might prefer, you know, a high ratio of von Willebrand to factor 8. I mean, having in mind also that certainly you don't want to keep the factor 8 levels too high as well.
Sure.
So I guess it all depends on what that baseline level is and what you're going to use it for. You know, if it's a one-time dose, you know, probably I will prefer to have, if it's low von Willebrand, to have the highest amount of von Willebrand. And then you can also, you know, figure out how you're going to dose it. You're going to dose it based on the von Willebrand
Sure.
level. You're going to dose it based on the factor 8 amount. So we usually go with the lowest, whatever it is, and that's how the way we dose it.
Yeah, and we certainly, you know, we lean toward using the 1-to-1 ratio since it's a little closer to what's normally in humans. But certainly what's available on your Medicaid and what's available in formulary, that's what you're going to use for most situations. And I don't think you're going to be wrong by choosing one over the other, but you really need to understand that there's a difference. Jonathan, anything to add to that?
yeah, I mean, I think I'm comfortable with all of the products that are on the market for most, you know, minor bleeds. There are some nuances that I think about with repetitive dosing, like a major surgery, where I don't want to drive factor 8 levels really, really high. And then maybe using a product where I can specifically dose von Willebrand factor and not give concomitant factor 8 or less concomitant factor 8 can be beneficial. But all of these products are very efficacious. I mean, if you look at further, which we didn't really talk about, there is sometimes some differentiation in the multimer size of the different products in the final preparation. So, you know, I think the bottom line is whatever is efficacious in your patient. So a majority of patients will be well treated with any of these products.
Sure. All right, here's a great question. It says, hello, I appreciate knowing what testing should I do as a GYN nurse practitioner. What should prompt me to refer to hematology? So is there a certain testing that you recommend being done, Jonathan, locally versus what should be waited for to do, or should just be a prompt referral based on bleeding history?
Yeah, that's a great question. I think it's going to vary depending on where you're located and what availability you have in your local lab. So if you're in a place that has to send out all von Willebrand factor studies, then my advice would be just to refer to your center, because if you have to send out to one of the big reference labs, I mean, I think as all three of us on this presentation are aware, there's a lot that can go wrong in the transportation sample, and you're going to get an invalid assay. So we're going to repeat it anyway. So I think the best thing to do is to refer to a coagulation specialist. You know, now certainly there could be things, as we talked about, besides von Willebrand disease that could cause bleeding too. So if you can get a quick coag profile, you know, a CBC, check a platelet count, make sure they don't have thrombocytopenia, you know, maybe even, depending on your institution, a PFA, platelet function analysis, a really quick and dirty screen of platelet function. Those are things that you can do. But I think the most important thing is if this has reached your threshold or you have a positive bleeding assessment tool score, that then you should refer to a hematologist.
The weather's totally cool in Houston. You never have those problems with transporting in Houston, I'm assuming, Miguel. Anything to add?
Oh, believe me, I know I fully agree with Jonathan. Yeah, you know, especially this big commercial laboratory, you know, there's so much variability. So definitely not. Now, one of the, I think, important points here is that a lot of times we see that, as a screen, they do PT-PTTs, and I don't think they're really good enough to tell you the truth for von Willebrand, definitely not. So don't think that because a PT-PTT is normal and the patient has bleeding symptoms, everything is normal. No, if you want to do the testing, then go ahead and do at least the von Willebrand basic. If not, then go ahead and refer them to one of the hematology centers, because a PT-PTT is not, is not sensitive enough to be able to pick up some of the von Willebrand disease.
Oh, certainly. And the majority will have a normal PTT. Yeah. That's a great point, Miguel. Yeah. So, all right, let's see the next question. So this one's a tough one. At what point do you consider bleeds to be severe enough to warrant VWF prophylaxis? Is this based on clinical presentation or just labs or both? You want to start that one off, Jonathan? That's a good one.
Sure. Yeah, that is the $1 million question.
Yeah.
I think it really depends on the patient and how much is the bleeding affecting their life, right? Yeah. So if you have a patient that, say, we've talked a lot about heavy menstrual bleeding. If you've tried antifibrinolytics, maybe hormone therapy with antifibrinolytics hasn't worked, or maybe there's a reason. I have some patients that just say, I don't want hormonal therapy. And so, or they're wanting to conceive, and so that's not indicated. So I think if you've done, you know they're iron deficient, you've replaced it, maybe you've had to do it a few times, they're refractory to kind of first phase therapy, which I think a lot of us think are antifibrinolytics, then I think it's worth having that conversation of, this is something we can do logistically for you. How would that work out? I have some even young girls that are in their teens that are adopted intravenous administration of von Willebrand factor concentrates very readily. I think a lot of it has to do with the individual patient and, kind of their home support system and their personal beliefs and goals. So it's kind of gets into the art of medicine, I think. But my opinion is, if it's impacting their daily life, even if it's not every day, but certainly, heavy menstrual bleeding, or in the wintertime, they have really bad nosebleeds that they're missing school and work. Well, then as a physician, we have treatments to help. And that's when you should really bring up the conversation of prophylaxis. Certainly GI bleeding, joint bleeding, that's a no-brainer. You're going to put those patients on prophylaxis. But some of the other more nuanced, I think, is a discussion with the patient.
Sure. Yeah. Recurrent joint bleeding, that makes sense. But some of them are tougher, and sometimes patients may not accept that jump. Miguel, anything to add to that?
No, I mean, I think that the good thing is that we got options, right? And that those are the ones you need to put on the table. I usually tell my patients, try it for 3 months and you come back and tell me if you see a difference or not. And most of the time they'll say, wow, I can function now those 5 days of my month very well compared to what I was doing. So definitely, I think it's important.
All right, we have a little bit more time here. So does on-demand mean only treatment of active bleeds? What about treatment, before potentially risky activities like, mountain, maybe hiking a mountain, riding, maybe mountain bike riding, things like that? What are your considerations for that? You want to start that out, Jonathan?
Oh, sure. I would think of it similarly to the advice I give my patients with hemophilia or other severe bleeding disorders, especially if they've done that activity and had a bleed. Then no question they need to do that. Are they going to go hiking in the mountains for a month? And they're going to be away from any type of treatment care facility? Well, at least, being trained, if they have severe bleeding, being trained how to administer an emergency dose would be pertinent in that scenario. I think it really goes to the type of bleeding that you have. So I have some patients, even we talked about levels of von Willebrand disease and variants and, type 2, 3, et cetera. But there are some patients with mildly low levels that bleed a lot more than others, Sure. So it really goes to what type of bleeding would you anticipate doing that type of activity. If it's just mucosal bleeding and you've been mountain biking before and you probably have never had bleeding, then you probably don't necessarily need a prophylax before that. But it really comes down to the type of bleeding you in particular experience, and what are the other players, and how you could get emergent treatment if the need would arise.
So I'm going to go through a couple quick ones, and we'll just do kind of lightning round questions here. So What about pre-treatment to patients before vaccinations? We'll start with type 1 von Willebrand's versus severe. Miguel, anything that you recommend for vaccinations, like a COVID vaccine, for example?
Yeah, I think that it all depends on the levels.
Sure.
Really, if patients have probably levels above 10%, there's usually not an issue, I'll say, with vaccinations.
Sure.
IM vaccination should be fine. Now, the COVID vaccine, sure, there's no contraindication for these patients. Actually, they're using a pretty small needle, so I wouldn't have any issue. Maybe that severe von Willebrand, if we know that it has very frequent bleeds, you might consider, doing maybe a low dose of concentrate before, but otherwise, I don't see an issue.
All right, Jonathan, let me give you a quick one here. If somebody has type 1, the parent probably does. Should I start with just the antigen or should I order the whole screening lab? So what do you think?
Yeah, good question. I still would do a factor 8 in antigen and an activity. The reason being too, there can be compound heterozygote, mom or dad could have one, defect and the child could inherit another one from the other parent. So I would tend to still do it all.
All right. And so, yeah, so I think so. And Miguel, I'm gonna give you the last one and then we're gonna close it out here. We have lots of questions. Sorry, we couldn't get to all of them. So this person works in an emergency room. They don't have access to full medical record. What would you recommend if having in the emergency room for traumas? If they have von Willebrand's, but you don't know the type, what if you're going to pick something to have available as sort of first line therapy, what would you recommend? So that's a great question.
I mean, we've talked a lot about tranexamic acid. It's been, actually there are multiple trials in trauma and OB. So it's a drug that all the ERs have available. I wouldn't hesitate to use it in somebody that comes in with a possible history of von Willebrand actively bleeding. I don't think it's going to really hurt that individual until at least you can get more information what type of von Willebrand. Because I mean, this is a common kind of scenario.
Yeah.
A lot of patients come in, there's a history of von Willebrand, and we have no idea what kind it is. Ideally, for them to come with some sort of bracelet or some ID that says what type it is. But I think tranexamic could be something that could be used very very fast, and everybody has it, at least to start with.
Big bolus dose. Yeah. All right. So we're finishing up here. So that's all the time we have for today, but you can keep sending your questions for follow-up on the Q&A at questions@cmeoutfitters.com or tweet @CMEOutfitters. You can visit the CME Outfitters Hematology and Virtual Education Hubs for additional activities, as well as resources, animation, and patient education. And finally, to receive CME credit for today's program, you have to complete the post-test and evaluation. Then you'll be able to download and print your certificate immediately upon completion. Thank you very much for joining us today. You can sign up for the live Q&A on March 24th. If you still have questions, we'll be available. Thank you for joining us. Be safe and